Everyone to today's webinar brought to you by No Diabetes by Heart, a joint initiative of the American Heart Association and the American Diabetes Association. I'm Sarah Bradley, Senior Managing Director of Professional Education and Engagement at the ADA, and I'm excited to be moderating today's session with two of our top experts who helped to plan the 82nd ADA scientific sessions. I'm joined by Dr. Sanjay Koul, cardiologist and professor of medicine at Cedars-Sinai Medical Center, and Dr. Netta Rizzoli, Director of Diabetes and Endocrinology Clinical Trial Program at the University of Colorado School of Medicine. So thanks to you both for being a part of this discussion. Before we begin, we'd like to recognize our No Diabetes by Heart founding supporter, Novo Nordisk, as well as our national sponsor, Bayer. Thanks to the both of you for your support. We'd like you to visit nodiabetesbyheart.org. This is where you can download patient handouts and information. You can access the latest guidelines, and you can also see our entire library of podcasts and webinars. So visit nodiabetesbyheart.org for that information. We have got a packed lineup, as you can imagine today, trying to distill as much information about the 82nd ADA scientific sessions in 60 minutes or less. We invite as many questions as possible, so please pop them in to the Q&A box. We'll try to address as many as we can throughout this entire webinar. So Sanjay, Netta, thanks so much for joining us. We might as well go ahead and dive right in. We have a lot to address. Let's start off with heart failure. One of the biggest topics that came out of this meeting, one of the biggest themes. Sanjay, why don't we start with you? Could we talk for a few minutes about the joint consensus statement from ADA and the American College of Cardiology?
Well, thank you, Sarah. Thank you for inviting me to this webinar. You know, the ADA recently published a multidisciplinary consensus report on heart failure, which was endorsed by the American College of Cardiology. And the goal of this consensus statement is to provide clear guidance to practitioners on the best approaches for screening and diagnosing heart failure in individuals with either diabetes or pre-diabetes. And the goal is to ensure access to optimal evidence-based management for all and to mitigate the risk of serious complications. And they have sort of leveraged prior policy statements by the American Heart Association and the American College of Cardiology to develop this consensus statement. The consensus statement is titled Heart Failure and Underappreciated Complication of Diabetes. So let me justify why they titled it Underappreciated Complication. You know, heart failure along with chronic kidney disease are the most frequent first complications of diabetes-related cardiorenal disease. And over the last 2 decades, decrease in mortality due to ischemic heart disease has not been matched by decreases mortality due to heart failure in diabetes. Hospitalization for ischemic heart disease declined at a faster rate than hospitalization for heart failure in patients with type 2 diabetes. So heart failure is the most important, earliest, most preventable and treatable cardiovascular complication of type 2 diabetes, yet it remains forgotten, often ignored, hence the term underappreciated complication of diabetes. So what I like to do is I like to focus on the key topics, beginning with the universal definition of heart failure. Again, they leverage this from the heart failure societies in America, Europe, and Japan. So they define heart failure as a clinical syndrome with symptoms and or signs caused by a structural and or functional cardiac abnormality and corroborated by elevated natriuretic peptide levels and or objective evidence of pulmonary or systemic congestion. One of the advantages of this consensus report is that the classification or staging for heart failure, they divide it into 4 stages. Stage A is the earliest stage. The patients are at risk for heart failure, but without structural or functional heart disease or abnormal biomarkers. So they are characterized by presence of risk factors. So diabetes is a form of stage A heart failure. Stage B is the pre-heart failure with structural or functional heart disease or abnormal biomarkers, NT-proBNP greater than 125, BNP greater than 50, or elevated cardiac troponins, but before development of signs and symptoms of heart failure. So many people with diabetes have stage B heart failure. Stage A and B heart failure are targets for prevention of heart failure. Primary or secondary prevention of heart failure. Stage C is characterized by symptomatic stage, and stage D is more advanced version of the symptomatic stage of heart failure. And stage C and D are targets for treatment of heart failure. So one of the two main elements in therapeutic recommendations were, how do we manage glycemic control in patients with heart failure? Why is this important? Because there are glucose-lowering agents that can worsen heart failure. So the advice that was provided to the practitioners is, if you're going to choose a glycemic control agent in heart failure, you should choose one that has the least impact, perhaps a beneficial impact on prevention of heart failure. And therefore, the SGLT2 inhibitors are recommended for prevention of heart failure, for glycemic control in patients with heart failure. If you cannot use SGLT2 inhibitors, then you can use a GLP-1 receptor agonist. There is some controversy that in patients with established heart failure, GLP-1 receptor agonists may not yield any benefit, but they are there for improving glycemic control. Therapies that you should avoid are the DPP-4 inhibitors, the TZDs, and the sulfonylureas. Insulin could be added if additional glycemic control is indicated. So this is the management of glycemic control in patients with heart failure. What about heart failure management in diabetes? For stage B heart failure, SGLT2 inhibitors is recommended for all. There's a new non-steroidal third-generation receptor antagonist called finerenone. It may reduce diabetic kidney disease progression and prevent heart failure. For stage C and D, they have sort of categorized the stage C and D based on ejection fraction. If you have heart failure with reduced ejection fraction, meaning less than 40%, then you have 4 foundational therapies: the beta blockers, the evidence-based beta blockers, the ROS inhibitors, characterized by ACE inhibitors and ARBs, or ARNI, sacubitril valsartan, as a substitute for ACE inhibitor or ARB, the mineralocorticoid receptor antagonists, and then the SGLT2 inhibitors. For heart failure with preserved ejection fraction, meaning greater than 50%, SGLT2 inhibitors may be considered along with the sacubitril valsartan as well as MRA. So now we have newer, more potent tools in our therapeutic armamentarium to mitigate one of the most common complications of type 2 diabetes, namely heart failure, both for prevention of heart failure as well as treatment of heart failure. So this brings me to the newer therapies that have been approved over the last 2 years for treatment of heart failure, regardless of presence or absence of type 2 diabetes. In 2020, dapagliflozin, an SGLT2 inhibitor, was approved for patients with reduced ejection fraction heart failure. This was followed in 2021 by the empagliflozin, another SGLT2 inhibitor, initially approved for reduced ejection fraction heart failure. And most recently, earlier this year, the label was extended to cover the whole spectrum of heart failure, regardless of ejection fraction, based on the EMPEROR preserved results. The ARNI, the sacubitril valsartan, was previously approved in 2015, specifically for management of patients with heart failure with reduced ejection fraction. And in 2021, the label was extended patients with chronic congestive heart failure with the language saying that the benefits are most clearly evident in patients with left ventricular ejection fraction below normal. So anything up to 55 to 60%, particularly in females, the RNAs were approved for that. So we have 3 newer therapies. There are some additional therapies, including vericiguat, which has also been approved, but these are the 3 major treatment advances in patients with heart failure, and they can be used regardless of type 2 diabetes.
Thank you for that overview. I'd like to bring you in, Netta, as the endocrinologist, talking a bit about that multidisciplinary approach to care, especially as it relates to heart failure. What are your thoughts? You were a part of a panel just talking about this topic. Would love for you to weigh in here.
Sure. I mean, Sanjay did a great overview of management of heart failure and thinking about heart failure in people with diabetes, because the risk that if you don't think about it, it's a condition. If you don't think about it, you are not going to screen. So it's very important to do the screening. But let's say if you have a patient who has diabetes and heart failure, it's very important from the endocrinologist standpoint that you use the right type of glucose lowering medication. And Sanjay mentioned we have enough evidence convincing us that SGLT2 inhibitors are the preferred glucose lowering medication in people with type 2 diabetes and heart failure. And the new change that happened recently in the past couple of years is the use of SGLT2 inhibitor is recommended independent of glycemic control. So if you have a person with type 2 diabetes and heart failure and A1C is at target, you're supposed to add SGLT2 inhibitor. And if the patient is at risk of hypoglycemia, you can cut back other medication. So that's an important change, that SGLT2 inhibitor should be used in people with type 2 and established heart failure, independent of glycemic control. And also, we have data that SGLT2 inhibitor is also protective in people who have a CKD and can improve the outcome of kidney disease. Therefore, we come up to a kind of time that SGLT2 inhibitor is recommended by endocrinologists to be used in people with diabetes, by cardiologists because of reduction in ASCVD and hospitalization for heart failure, by nephrologists because we have data that SGLT2 inhibitor can slow down the progression of kidney disease. So it's very important that, and also primary care, who take care of a lot of patients with type 2 diabetes with comorbidity. So I think this multidisciplinary approach is very important, and it cannot happen if there is not enough communication among these specialties. And because the rate and prevalence of diabetes and its comorbidities is increasing, it's impossible to kind of rely on one specialty to kind of take all the responsibility. So multidisciplinary approach is recommended and is preferred. And it will be a little bit difficult if there is not enough communication among a specialty or people who take care of patients with diabetes to provide optimal care. So communication is important, feeling responsible that whenever you have the first touch with a patient with diabetes and heart failure or CKD, you are responsible, no matter what specialty you are. So data shows that we are not doing a great job in providing this type of care, especially like SGLT2. From 2015 to 2019, the rate of prescription of SGLT2 has increased from like 6% to 10%, 12%. Still, we are not at the optimal rate, and there is a huge gap between our guideline and recommendation and real life, what is happening in practices. And looking at, there is a paper in JAMA that look at different the rate of prescription in different races or ethnic group. And unfortunately, we see that underrepresented minority, especially African American, female, and people with low socioeconomic status are even prescribed at the lower rate of SGLT2 inhibitors. So it's important to provide optimal care and translate our evidence to practice.
Wow, important findings on the topic of heart failure. I know we already have some questions coming in, but let's keep going because there's so many more topics to discuss. Can we move on to chronic kidney disease? Sanjay, kicking it back over to you, there was a new KDIGO guideline session that came out talking about chronic kidney disease. Do you want to give us an overview of what those guidelines said?
Yes, the 2022 KDIGO guidelines focus on a holistic approach for improving outcomes in patients with diabetes and CKD. The foundational basis is the lifestyle intervention, and there are the four main elements: healthy diet, physical activity, smoking cessation, and weight management. As far as healthy diet is concerned, we can go deeper into what is recommended, but what I'd like to focus on is if we can avoid three things, processed meat, refined carbohydrates, and sweetened beverages, I think that would make a huge impact on the lifestyle modification. Physical activity, 2.5 hours over 1 week is what the recommended goal is. So these are the foundational therapies for mitigating cardiorenal risk in diabetes. The first line drug treatments are target either blood pressure control, lipid control, and the diabetes control. For blood pressure control, ROS inhibitors are recommended, especially if the patients have proteinuria. So the ACE inhibitors or the ARBs are considered as first-line therapies. Moderate or high-intensity statin for controlling LDL cholesterol is also considered a first-line therapy. If you're diabetic, metformin, especially if the eGFR is greater than 30, is considered first-line. And then SGLT2 inhibitors are also considered first-line, especially if eGFR is higher than 20. And you can continue it even if the eGFR drops to less than 20 or until there is dialysis or transplant. So this is the new recommendation, lowering the threshold for initiation of SGLT2 based on eGFR, and then continuing it even if the eGFR drops. This is the first line. You check your hemoglobin A1C. If the glycemic control is not under control, then you can add the second line therapy, such as a GLP-1 receptor agonist to achieve the individualized glycemic target or persistent albuminuria. If you still have albuminuria, non-steroidal MRA like finerenone, especially if there is persistent albuminuria and the potassium is normal, less than 5.5. For blood pressure control, you could add a dihydropyridine calcium channel blocker or a diuretic if the blood pressure is not under good control. And if the lipids are not under good control, the second line would be ezetimibe or PCSK9 inhibitors, or even icosapent ethyl, which is a fish oil. You can use antiplatelet agents for clinical atherosclerotic cardiovascular disease. So the other glucose-lowering drugs are, if needed, to achieve individualized glycemic targets, such as DPP-4 inhibitors or even insulin. If you have resistant hypertension, then a first-generation steroidal MRA, such as spironolactone or eplerenone, could be used for resistant hypertension, especially if the eGFR is greater than 45. But eGFR cutoff is higher here because there's a risk of worsening renal function and hyperkalemia. So this is basically the most recent guideline recommendation. Just one point I want to make, the ADA and the KDIGO have come up with a consensus statement on CKD, which will be coming out, I think, in October in Diabetes Care, headed by Dr. Bakri from the ADA side and Dr. Boer from the KDIGO side. There are subtle differences in terms of what treatments to use, especially for CKD. The ADA recommends the non-steroidal MRA finerenone as a grade A recommendation, whereas the KDIGO recommends it as a 2A recommendation for finerenone. They prefer SGLT2 inhibitors to be used before you add on the finerenone. So I'm going to stop there, and if Netta has any comments to make, maybe just I should add, there is an increasing emphasis on how to screen for chronic kidney disease in type 2 diabetes. So far, most primary care physicians and specialists have been using eGFR and have been ignoring the UACR. And both are very important for prognostication as well as for predicting therapeutic response to treatment interventions. So we used to break them down as micro albuminuria versus macro albuminuria, which they have abandoned. And there is this heat map where you quantify urinary albumin creatinine, and if it is less than 30, that's the normal. 30 to 299 is the A2 range, the moderate amount of albuminuria. Severe albuminuria means greater than 300. Similarly, the eGFR cutoffs also have their 506 cutoffs, and you can, based on this heat map, identify patients who are at higher risk so that you can target optimal medical therapy in those high-risk individuals. So the emphasis is for screening, use both eGFR as well as UACR.
Well, great. Yeah, thank you for that overview. A lot of discussion about CKD. Netta, passing it over to you as the endocrinologist, thoughts and comments on all the CKD things to come out of this meeting.
Sure. What is exciting and something relatively new to us as endocrinologists is this mineralocorticoid receptor antagonist, like finerenone that Sanjay mentioned. So we know that activation of mineralocorticoid receptor causes increased inflammation and fibrosis in kidney. So it makes sense blocking this receptor will improve progression of kidney disease. So when trial like Credence looked at the SGLT2 in patients with kidney disease, even though it decreased the risk of kidney outcome, including worsening of eGFR or end-stage renal failure or mortality, still there were residual risk after SGLT2 inhibitor. That's when the rationale of mineralocorticoid receptor antagonism kind of came. Maybe we can add another agent that decreases the risk of kidney disease, progression of kidney disease further. And non-steroidal mineralocorticoid receptor antagonists, we can consider them a new class because they are different than the first generation, like spironolactone, in regard to some other effects, including gynecomastia or the severity of hyperkalemia. So what are the evidence of finerenone in people with diabetes, kidney disease that can improve kidney outcome and also cardiac outcome? We have two trials, Fidelio and Figaro, and these are the patients who had some degree of kidney disease, including low eGFR and positive albuminuria. And depending on the range of the albuminuria, they had to have a certain level of eGFR to qualify for this study. And the difference between Fidelio and Figaro, they both had diabetes, kidney disease, but in Fidelio, the primary endpoint, the focus was on kidney outcome. In Figaro, the focus and primary endpoint was on cardiac outcome, including 3-point MACE and hospitalization for heart failure as a composite outcome. So both these trials are published in New England Journal of Medicine, but what was new in ADA, the pooled analysis of these two trials with the name of Fidelity. They showed in Fidelity, which add up to more than 13,000 people with diabetes kidney disease. They are at risk for progression of kidney disease and also heart disease. When they looked at the specifically kidney outcome, they defined it as end-stage renal disease, renal mortality, and worsening of eGFR by about 54%, which kind of translates to doubling of creatinine level. So they saw that in these 13,000 people, the risk of the cardiac event went down by 23%, and the progression of kidney decreased by about 14%. So non-steroidal mineralocorticoid receptor antagonist, finerenone, when it's added on top of other medication, including maximally tolerated dose of RAS inhibition, and a small percentage of people in this cohort were on SGLT2 and GLP-1. On top of all this medication, you can decrease the risk of progression of kidney disease by about 14% and decrease the rate of MACE and hospitalization for heart failure by about 23%. There are a lot of kind of post hoc analysis and subgroup analysis. First of all, this protective effect was evident independent of level of eGFR or UACR. So when they looked at the different category of UACR and different category of eGFR, the benefit was there and it was not heterogeneous. And even though it was only a small percentage of people on SGLT2, less than 10% or almost 10%, when they looked at the people who were on the background of SGLT2 versus the one that they were not SGLT2, finerenone had a similar protective effect. You don't need a first step of SGLT2 to see benefit of finerenone. But again, I want to mention that it was a small subpopulation that they were on SGLT2 as a background. So Fidelity, this pooled analysis kind of confirmed with a more robust kind of evidence that finerenone can be beneficial in people with diabetes kidney disease. It comes at a 10 milligram and 20 milligram dose, and depending on potassium and eGFR level, they started with lower dose and they could go up to the higher dose or come back to lower dose. And that's something as endocrinologists, we need to think about it. It's not glucose lowering medication, so sometimes we forget about the other medication that can protect our patient with kidney disease from future heart problem or progression of kidney diseases.
Yeah, Ned, I'm glad you brought that up because as you both are talking, this team-based approach to care, what does something like this mean for cardiology, nephrology, endocrinology, primary care? How does everybody work together? How does everybody communicate? Curious to hear if either one of you have any guidance or suggestions for our audience about that.
I think I will start first. The era that this is my responsibility or my cardiology colleague or nephrology colleague responsibility is gone. We all need to think about it. And if we have a medication that is with the evidence of protecting people from worsening of cardiac or renal disease, we need to start them on a first touch. If I'm lucky to see a patient as a first time, that's my responsibility. If my cardiology colleague is going to see a patient with heart failure and is not on SGLT2, that's his responsibility to start first. And maybe there was actually a study that number one barrier for cardiology to start SGLT2, they are afraid of hypoglycemia. I mean, we all need to learn and educate ourselves and our colleagues to become more comfortable. And whoever has the first touch with patient, that's his or her responsibility. That's my approach and recommendation.
Good approach. Sanjay, anything else to add there?
No, I think I agree. Diabetes is at the intersection of so many different organ systems, and I don't think siloed care is justifiable anymore. We all have to communicate. It has to be interdisciplinary, and the patients have to play a very important role in how we manage cardio-renal metabolic disease.
Very good. Before we leave the topic of chronic kidney disease, do either one of you want to touch at all about under-resourced patients, about how some of these findings could either help or there still might be some barriers when we're caring for our patients who are under-resourced?
I thought that this is a huge problem, and I don't have any answer for it, and I don't think that our healthcare overall has an answer for it. We know the problem. We know that people with low socioeconomic status, maybe underrepresented minority, they don't get all treatment that have proven evidence. And we need to work with our patients, at least provide them with the optimal care, and sometimes it's not feasible. I mean, if the copay is so high, or if they don't have insurance coverage for certain medication that I know we have evidence that protect them, it's heartbreaking, but I don't know if I have any answer. And that's a bigger discussion that sometimes I feel is out of my control.
Yeah. Yeah, very good. Sanjay, anything to add?
No. That's
okay.
Agree.
All right. Just want to remind our audience to continue to put your questions in. We'll try to get as many as possible in just a few minutes. But before moving into question and answer, let's talk about weight loss. Big information coming out of the 80-second scientific sessions on weight loss. Netta, would love to talk to you for a few minutes about the SURMOUNT trial and those implications for clinical practice.
Sure. I think this is one of the most exciting trial that I came out in this ADA, and we were all excited about the result of this trial. SURMOUNT trial tested the efficacy of tirzepatide, which is the first in the class of dual incretin, GLP and GIP agonist, to see what is the effect of tirzepatide on weight loss in people with obesity and no diabetes. So about 2,500 people with obesity defined as BMI more than 30 or BMI more than 27 with one comorbidity were enrolled in this trial. They were randomized to either tirzepatide or placebo, and there were 3 different doses of tirzepatide: 5 milligram, 10 milligram, and 20 milligram. And the primary endpoint of the study was percentage of weight loss after 3-year follow-up, or percentage of people who had lost 5% of their weight. So the exciting news was this medication was very effective. It was surprisingly effective, that it was comparable to our bariatric surgery result. So let's kind of briefly summarize the result of this study. At the lower dose of tirzepatide, the amount of weight loss in average was 15%. At the higher dose, which was 10 milligram or 15 milligram, in average, weight loss was about 20%. It wasn't that much different between 10 milligram and 15 milligram. So, I mean, this is a huge amount of weight loss. In average, 20% of weight loss with a medical treatment. So finally, we have a drug that is working for weight loss. And the other outcome was percentage of people who lost 5%. And it was more than 90% of people who were treated with tirzepatide lost 5%. So the result was huge. It was super exciting. And even a certain, about 20% of people, 1 out of 5, lost 30% of weight, which is comparable to bariatric surgery. Just taking a medication to lose as much weight as you lose with a bariatric surgery, that's amazing. But I just want to bring up a couple of points. First of all, there, like any other medication, there was variability in result. What it means that, like, as I mentioned, 23% of people lost 30% weight, and about 3% or 2.5% lost no weight. So that's interesting. And about 10% of people lost less than 5% of weight. So the range between no weight loss and losing 30% of weight, it's amazing that in this era of precision medicine, personalized medicine, it will be interesting to learn who are the people, what characteristic we need to look at people that are responder versus non-responder, even though average was great, but who are those non-responder versus responder? I thought that will be something in future will be good to know. And then the other issue is, like any other incretin agonist, GI side effect is a problem, even though it wasn't way larger than GLP-1 receptor agonist, but it's still the medication required almost 5 months of up titration. So you want to do a slow titration to go to the maximum dose. And sometimes this kind of titration could be a problem in the real time or real practice, because when people are in clinical trial, there are a study coordinator calling them, making sure that they do titration following the trial or protocol. But in real life, it becomes a little bit more difficult for people to follow the titration. So that's something should be considered. And the other thing is, we see that a significant weight loss comparable to bariatric surgery, but what I will see in future, it will be interesting to see in a real randomized trial whether this medication can be comparable to bariatric surgery in regard to weight loss and outcome of the trial. And I want to just touch base about the cost and affordability, because it's a huge breakthrough in the science. We know the evidence, but like anything else, if we have a large epidemic of obesity, if it cannot be afforded by majority of people or are not covered by insurance, then we are not going to see the effect of this medication in a larger scale. And last thing that I want to mention and briefly is in this population of 2,500 obese non-diabetic people, 40% of them had prediabetes. And after significant weight loss, 95% went to normal glucose tolerance. So there is a remission in this glycemia, or conversion from prediabetes to normal glycemia happens with weight loss, which was expected. In addition to improvement in glucose, there was significant improvement in lipid profile, significant improvement in blood pressure. So obesity comes as a kind of problem with all of this metabolic disorder, that improving weight and causing weight loss, it was expected, but it's always good to see that how much improvement in the glucose, lipid, and blood pressure was associated with weight loss after tirzepatide. So
yeah, a lot of discussion about those findings for sure. Sanjay, want to hear your perspective. Anything you want to add here?
Well, clearly a potential game changer, but as Netta mentioned, one has to overcome the deep chasm of cost and affordability hurdles. And, until we do that, it will remain a conceptual advance, but we really have to make sure that this is a true therapeutic advance by having many people who need it have access to these interventions. Netta also talked about remission. I think that's very exciting. Now, in SURMOUNT, people with prediabetes were enrolled, 40%. People with diabetes were not. But in the SURPASS program, a post-hoc analysis was done to see how many people would achieve a hemoglobin A1C less than 5.7% as well as greater than 5% weight loss. Now, 5.7% is the threshold for normal versus pre-diabetes, and up to 40 to 50% of patients were able to achieve that, highlighting the potential for this, the holy grail of type 2 diabetes treatment, which is remission, the concept of remission, which the American Diabetes Association, along with ASD, defines as hemoglobin A1C less than 6.5% for at least 3 months off therapy. They allow metformin, but off specific glucose lowering therapy. And in the SURPASS program, we were able to achieve it. About half of the patients were able to achieve not only less than 6.5%, but up to 5.7%. So this is very promising. We have to do these studies to see if the remission is achievable. But for me, that was a very interesting point. Netta, maybe if I can talk about the step 1 study with semaglutide. One important topic I want to talk about is that you have to maintain this treatment on a chronic basis in order for weight loss to be persistent. In the step 1 study, the extension of the step 1 study, about 300 odd patients stopped taking their semaglutide, 2.4 milligrams, and they were followed for another 1 year. Nearly 2/3 of the weight loss was regained in the semaglutide arm, highlighting the need for chronic treatment with these agents, which again poses a challenge as far as affordability and cost is concerned. But yes, impressive weight loss, exemplary discovery and innovation. Now the challenge is how do we bring it back to really affect the lives of our patients.
It was interesting that a lot of sessions that I went on obesity in this ADA, a lot of people were comparing now obesity to hypertension. Like when you start people on blood pressure lowering, you kind of talk to them and you have that feeling yourself that you need to keep them on this medication for a long period of time. And maybe we need to approach obesity or weight lowering medication with the same approach, that when you start, you need to keep them on this medication for longer period of time, not just for intervention, but for maintenance. So I agree with you. And the other new concept I learned from ADA, there was a lot of discussion that maybe 10 is the new 7, like 10% weight loss is something that we need to focus rather than A1C of 7, because that 10% weight loss or significant weight loss will take us not only to the glycemic goal, also to the blood pressure goal and lipid target. And one thing that I want to bring up is the weight loss you see by tirzepatide or semaglutide. These are the 2 great proven weight loss medication that we have, are way more significant in people with no diabetes than with diabetes. So when you develop diabetes, the efficacy of this medication on weight loss goes down. Nobody exactly knows why is that. Is it because of metabolic inflexibility in diabetes, or maybe there are some, it's outside the kind of outline of this talk, but the earlier you treat obesity before metabolic disturbance, it's better, and you will have less comorbidity of obesity.
Yeah, I just want to briefly mention, Jennifer Green presented an exploratory post hoc analysis of the SURPASS program. And what she observed was that only 25 to 28% of the hemoglobin A1C drop could be explained or attributable to weight loss. So the drug does things besides just the weight loss, maybe improvement in insulin sensitivity, maybe beta cell function and other things. So that's what is exciting as far as the hemoglobin A1C lowering effect of this drug is concerned.
Well, very good. It seems like you're answering some of the questions that are coming in as we're going through this conversation. Just invite people to continue to put those questions into the chat. Let's talk about one more study with the time we have left, or one more topic, ASCVD risk. Sanjay, could you talk a bit about the Ischemia trial?
Yes, one of the most controversial topics in all of cardiology is how do we manage patients with stable ischemic heart disease, or what we call stable coronary artery disease? And traditionally, there are two ways we can deal with it. One is you take them to cath lab. If you identify a stenosis, you put a stent in. So, and you continue the medical therapy. We often call this as the early invasive therapy. And then the other strategy is we don't take them to the cath lab, you don't put a stent in, but we treat them with optimal medical therapy, lower their lipids, control their blood pressure. And over the past decade and a half, there have been several studies that have been conducted, Courage, Barry 2D, and now Ischemia, trying to find out whether the invasive strategy is better than conservative strategy, and not only improving survival, but also improving the symptom of chest pain and improving quality of life. And Ischemia was the largest study. It enrolled over 5,000 patients, but also enrolled about 2,500 or more patients with type 2 diabetes. So it's one of the largest, in fact, the largest study that in the diabetes cohort. And even what ischemia showed, that patients with diabetes were at an increased risk for myocardial infarction and cardiovascular death, as well as spontaneous non-procedural myocardial infarction. And despite increased risk of clinical outcomes, there was no benefit with invasive over conservative therapy in patients with diabetes. So kind of a little bit of disappointing result. So thus PCI or CABG is not recommended for either one vessel or two vessel coronary artery disease without left anterior descending disease. CABG surgery is endorsed as class 1 recommendation for multi-vessel disease with ejection fraction less than 35%. So patients who have heart failure or LV systolic dysfunction and have multi-vessel disease, bypass surgery is recommended as class 1. For multi-vessel disease with normal ejection fraction, or for proximal left anterior descending artery, both PCI and CABG recommendations have been downgraded to a class 2B recommendation, which is reasonable, even in patients with diabetes, which was considered to be a high risk category. So the ischemia results are confirmatory of the previous studies like Barry 2D and Courage. And so consequently, the guideline recommendations have been downgraded in support of revascularization for stable ischemic heart disease. So that was the main finding from ischemia.
All right.
Now, one point I want to make is that the optimal medical therapy here was basically, high intensity statin therapy, beta blockers, and anti-anginals, and so on and so forth. Very few patients were treated with SGLT2 inhibitors, GLP-1 receptor agonists, or PCSK9 inhibitors, or icosapent. These are therapies that have shown to have an incremental benefit in reducing cardiovascular risk beyond the other therapies. So if we were to conduct this study in the modern era, it wouldn't surprise me that perhaps the medical therapy alone, the optimal medical therapy, may actually beat the revascularization strategy.
Well, good. Thank you, Sanjay. Neda, anything to add there?
No, I was actually going to make that comment that Sanjay at the end made, that the intervention were compared to medical therapy, that medical therapy we know from evidence that is not yet optimal, and we have room to increase the GLP-1, SGLT2, finerenone, and if all of them get added, you never know what happened with medical therapy. Maybe it will be superior, but I don't know.
Well, good. Well, we have a few minutes left for questions. Let's start from the bottom first, just because it's fresh. So how do you know if a person is stable? With stable disease would need revascularization?
Well, I think it's based on the symptom status and also on the extent of ischemia on a stress test, as well as the extent of the atherosclerotic obstructive coronary artery disease. So if you have multi-vessel disease, meaning more than 2-vessel disease, involving a proximal LAD and the LV ejection fraction is 30-35%, then I would not wait for optimizing medical therapy. This would be the sort of patient that would benefit both in terms of survival advantage as well as symptomatic benefit with revascularization, specifically bypass surgery. Patients who have proximal LAD and have moderate to severe ischemia, I would try initially medical therapy, and if they fail medical therapy, you can always refer them for intervention. So what we used to believe that all patients, multivessel disease patients, should undergo revascularization is no longer true. I think the LV ejection fraction plays a more important role in triaging patients for revascularization versus medical therapy.
Mm-hmm. Questions about tirzepatide. One question, what's the cost?
Prohibitive.
I first want to emphasize that tirzepatide is not yet approved for treatment of obesity. So very recently, it was mid-May of this year, 2022, tirzepatide received FDA approval for treatment of diabetes. And when you ask for the cost, it's always difficult question. Usually for a new drug, they provide a lot of promotional kind of discount, some card, but out of pocket, don't quote me, but what I heard, if you go out of pocket without any coupon or something, is up to $1,000 per month. So the cost is like, it's higher. I don't know if people can afford it out of pocket, but it's kind of in that range. I don't know the exact cost, but something in that area.
Yeah, the retail cost is around $12,600 per year. But that's the retail cost. What the patients have to pay out of pocket varies according to what their insurance plan is. But that is going to be a major challenge.
We touched upon this slightly, but just to clarify, does this treatment, does tirzepatide, is it needed to continue to maintain the remission of diabetes?
Let's talk about SURMOUNT. Was about 3-year study. 40% of people had pre-diabetes, and they had a remission to normal glucose tolerance. I heard SURMOUNT is going to follow up the people, so we don't have data on that. But on SURPASS program, which was tirzepatide in type 2 people, which showed a significant remission on diabetes, we don't have a long-term follow-up after stopping tirzepatide. What happened to rate of remission? We don't have that data, but from other studies, like very low calorie diet or intervention that causes remission, if people start regaining weight, usually diabetes kind of reappear. That's why we never say they cause cure of diabetes. It's remission. They might go to normal glucose tolerance or pre-diabetes, and if they start gaining weight or changing their lifestyle, usually there is a recurrence of hyperglycemia or dysglycemia. I don't think they have any data on the follow-up of the SURPASS people who went to remission, but that's my hunch and prediction.
Yeah, it's a defensible hypothesis that needs to be tested. It hasn't been tested. There are some preliminary promising evidence, but we have no idea how long they need to be on it. Do they modify the genotype, or they just modify the phenotype temporarily? At this point, we don't know that, but it's something that needs to be studied.
There is a link in the chat for all of you to complete your evaluation of this webinar. So that link is in the chat. You'll also receive the link in your email. Please take it so we know how to customize information and learnings for you moving forward with our No Diabetes by Heart initiative. Just wanted to put a plug in for that. Going back to our questions, Sanjay, a clarifying question about the KDIGO guidelines. They are not yet finalized. They're not yet published. They'll be published later this year. Is that correct?
That is correct. The whole goal of this webinar was to recap what was presented at the ADA. Mm-hmm. And what I presented is still not finalized yet. There was a lot of back and forth. There was public feedback session, and they're still in the process of incorporating all those recommendations. And the finalized guidelines would come somewhere mid 2022, and the consensus statement ADA and the KDIGO will be published somewhere in October. Don't hold me to those dates, but this is what the preliminary. That's the goal.
Well, that sounds great. Another question coming in about the MACE findings, and I don't know if any of you are familiar with this, about finerenone and when we can expect that kind of data and information coming in, the Figaro data as it's related to the reduction of MACE.
Figaro has been published, and Figaro tested or enrolled about 7,000 plus people who had diabetes, kidney disease, and they looked for major adverse cardiac events and hospitalization for heart failure. So the primary endpoint of Figaro was non-fatal MI, non-fatal stroke, cardiovascular mortality, and hospitalization for heart failure, which overall in this population, diabetes with kidney disease, that also were on maximum tolerated dose of RAS inhibition, it showed reduction in major adverse cardiac event. We don't have a trial on finerenone and people without kidney disease. So if that's the question, I do not think there is a trial ongoing, or at least I'm not aware of that. I guess the question is whether we have a trial in people with type 2 diabetes and established cardiovascular disease or high risk cardiovascular disease, whether we have a MACE trial on that. And as far as I know, this medication has been tested in patients with diabetes and kidney disease.
Ned, I would add that there is a trial that is currently ongoing called Fine Arts. And Fine Arts will be in heart failure with ejection fraction greater than 40%. And there are also other smaller studies using, along with SGLT2 inhibitors. One study is called the Confidence Study, where the primary endpoint is UACR to see whether the albuminuria burden is lowered, monotherapy versus combination therapy. And I think Dan Wilson, who was on the chart, also sent a note saying that Find CKD is another trial that is ongoing with finerenone.
But the question is whether we have something like a CV outcome trial, patient with type 2 diabetes without any kidney problem at the background and looking at the.
I'm not aware of it. Maybe Dan might be. You're right. Absolutely right. Yeah, like we had with SGLT2 or GLP-1 receptor agonists.
And that is where I believe we have to end today. A tremendous amount of information in a very short amount of time. Thank you so much, Neda and Sanjay. What an absolute pleasure to be chatting with you about the 82nd scientific sessions and all the information that came out of this. For more information, visit nodiabetesbyheart.org. We also want to thank our founding sponsor, Novo Nordisk, and our national sponsor, Bayer, for their support of this initiative. Take very good care, and thanks so much for being a part of our webinar today.